Good afternoon, everyone, and welcome to the Texas Collaborative for Healthy Mothers and Babies webinar on Maternal Early Warning System, MEWs, triggers and notification. We're very pleased to have our members of our executive committee to present this webinar. We have Dr. Catherine Eppes from Baylor College of Medicine and Dr. Christina Davidson, also from Baylor College of Medicine. They are both our co-chairs of the TCHMB Obstetric Subcommittee. In addition, we have Dr. Suzanne Lundeen from Harris Health System and Ben Taub, and Kristen Thorp from Texas Children's Pavilion for Women. So we're very pleased to have all of them to share their experience, and we will welcome questions from the group. And if you could please use the question and answer link on the webinar to ask any questions over the course of the webinar, and we'll try our best to respond during the webinar itself. So with that, I'm going to turn it over to Drs. Eppes and Davidson. Thank you.
Thank you, Divya. This is Christina Davidson. Can you hear me? Can everyone hear me? Okay.
We hear you.
Okay. So the objectives for today are that we're going to compare and contrast effective and non-effective systems of escalation, and we're going to discuss important communication strategies in the maternal early warning system. And then we'll leave some time at the end for questions and answers. So we've talked about the maternal early warning system in a prior webinar, and we've also talked about it at the in-person learning collaborative, but we just felt like it may be a little bit better to go through actual examples and illustrations of it. What the maternal early warning system is a system of escalation based on maternal vital signs. And it has been developed to facilitate timely recognition, diagnosis, and treatment for women developing critical illness. So we're not going to have video recorded simulations. We're going to do more of a storyboarding this time, but the goal is to kind of walk through scenarios so that you can see what we're really trying to describe. We recognize we've been working on OB hemorrhage since we've started all of these collaboratives and webinars. However, we also want to show how a maternal early warning system can apply to hypertension. We're going to present two clinical scenarios and compare and contrast the different escalation systems. The first scenario is one potential approach. However, as you will see, it highlights potential gaps in response to patients with abnormal vital signs, as well as in the notification and management. The second approach is our illustration of the maternal early warning system and what we consider to be the essential components to timely recognition and response to worsening maternal condition. As we go through these two scenarios, please keep in mind that the goal is to treat severe hypertension within 60 minutes. So these two scenarios will show us how to achieve those goals. Now I'm going to turn it over to Susie Lundeen to walk us through the first scenario.
So I'm going to start the first scenario, and this is a pretend situation someplace in Houston. So first, beginning of the shift at 8 o'clock in the morning, the patient care assistant goes around checking her vital signs on the mother-baby unit, and she encounters a severe range blood pressure of 165/103. The PCA continues checking on her other patients, and then about 45 minutes later at 8:45, she goes into the patient's electronic health record and she documents that blood pressure of 165/103. About 5 minutes after that, the primary provider happens to log on to the electronic health record and is given the best practice alert for severe hypertension. The provider then calls the patient's primary nurse, and she requests the nurse to validate the vital signs and go check on the patient. About 15 minutes later, the nurse makes it to the room after she passed some other meds, and she assesses the patient and rechecks the vital sign. About 9:20, she goes ahead and she calls the primary provider back, and she informs her that the patient's blood pressure is now 170/106, and the patient's reporting a new onset headache. At that time, she receives no orders. The provider tells her that she will check on the patient when she makes her morning rounds in just a few minutes. Then about 10 o'clock, the primary provider makes it to the bedside. The patient has a headache, 7 out of 10, and she's also reporting now blurred vision. The primary provider goes ahead and orders some pre-E labs, nifedipine 10 milligrams PO now for the blood pressure, Tylenol 650 milligrams for the headache, vital signs every 15 minutes until the severe range hypertension is resolved. And she also asked the patient to be transferred to a higher level of care for magnesium sulfate administration for seizure precautions. So about 15 minutes after that, the nurse brings the antihypertensive medication and Tylenol to the bedside and she administers it to the patient. She also asked the PCA to go ahead and start taking the vital signs every 15 minutes. And then at about 10:45, the blood pressure is out of severe range at 155/89. So just to give a brief summary of the times that just transpired in this example, the MEWs trigger occurred at 8 o'clock. The provider got to the bedside at 10 o'clock. The amount of time from the severe hypertension to treatment is 135 minutes. And then the amount of time of resolution of that severe range blood pressure is 165 minutes. So that's just one example. And now we're going to move on to another example. And Kristen's going to talk about that example.
Okay, so somewhere else in Houston, it's 8 o'clock in the morning and the PCA is checking the vital signs and validating. The initial blood pressure that she gets is 165/103. And so she looks on her badge and she sees that she has a MEWs trigger. The vital signs in the red box are going to need to be validated within 5 minutes. She does validate that vital sign and she immediately notifies the RN of the MEWs trigger vital sign. At 8:05, the RN evaluates the patient and validates the vital signs again. And at 8:07, the RN calls the responding provider using the SBAR reporting tool. Hi, Dr. Jones. This is Lisa calling to report that Ms. Smith had a MEWs trigger with a blood pressure of 165/103. Her other vital signs are normal. She has a heart rate of 89, respirations of 17, pulse ox of 99%. She was admitted earlier today with elevated blood pressure and a headache to evaluate for preeclampsia. She's a 35-year-old G4P3 at 32 weeks gestation. Her headache remains on a scale of 5 to 10. She denies any visual changes and her DTRs are 2+. The patient needs a provider assessment now. I will see you at the bedside within 15 minutes for an evaluation. At 8:10, the bedside nurse notifies the charge nurse of the MEWs activation. And at 8:20, the responding provider is at the bedside to evaluate the patient, which was within 15 minutes of the initial call to the responding provider. At 8:22, the responding provider and the nurse discussed differential diagnosis, planned frequency of monitoring and reevaluation, workup, and plan of care, including orders. So in order to verify that everything that was decided upon has been understood by both providers involved, we use closed loop communication to ensure the information is conveyed by the sender and understood by the receiver. And this is just, this little blue box just kind of illustrates that the responding provider will assume patient care responsibility until the MEWs is resolved or the patient is handed off to another provider, whichever comes first. Report findings to patient's primary provider is what occurs at that time. At 8:28, the RN administers the antihypertensive. And at 8:40, the RN documents MEWs trigger and admits in the electronic health record. And at 8:43, the PCA takes the vital signs Q15 after the medication administration. And at 8:58, we have a blood pressure of 155/89. So just to summarize the time events for this scenario, the time of the initial MEWs provider to bedside was 8:20. The amount of time from severe hypertension recognition to treatment was 28 minutes. And the amount of time to resolution of the MEWs trigger was 58 minutes. Okay, I'm going to hand it over to Dr. Davidson.
So I'm going to compare and contrast the two scenarios. And again, keep in mind, as you can see at the top of the screen, that the goal is to treat severe hypertension within 60 minutes of getting a severe range blood pressure. So in scenario one, what we saw was that the patient care assistant takes the vital signs and enters them into the electronic health record at some point once she finished getting the vital signs for everyone that she's assigned to. And this process is the same regardless of the vital sign value that she gets on any individual patient. In contrast, in scenario 2, when the PCA takes the vital signs, if it is a recognized MEWs trigger, she immediately notifies the nurse. Going back to scenario 1, the recognition of severe hypertension only occurs once there's a best practice alert after logging into the electronic health record. And this time obviously can be very variable. In the scenario we saw, it was about an hour later when a provider logged into the medical record and saw the best practice alert, but this could be anywhere from 30 minutes to 3 or 4 hours later. In contrast, in scenario 2, the recognition occurs as soon as there's a vital sign abnormality that would connotate a MEWs trigger. And that MEWs trigger is then communicated directly to the provider from the nurse using SBAR communication. Again, going back to scenario 1, the validation of the abnormal vital sign didn't occur until over an hour after the severe range blood pressure reading was obtained initially by the PCA. However, in scenario 2, that validation occurred immediately after a severe range blood pressure was obtained. And the validation is just to ensure that you're not getting an erroneous error, that it's an actual real severe range blood pressure or whatever the vital sign may be. In scenario 1, the response was that a provider didn't get to the bedside until 2 hours after the initial severe range blood pressure. In contrast, in scenario 2, the provider was at the bedside in 20 minutes. And in scenario 1, it took over 2 hours from time of the severe range blood pressure to treatment of that blood pressure. However, in contrast, in scenario 2, time to treatment was only 28 minutes. And then time for that MEWs trigger to resolve was 165 minutes in scenario 1. And in scenario 2, that time was less than an hour. So we see the goal of treating severe hypertension within 60 minutes is only met in scenario 2. And we're going to go through in more detail a protocol for the maternal early warning system. I will turn it back over to Dr. Eppes now.
Hi, good afternoon, everyone. So after using the before mentioned examples to illustrate different ways to escalate or get a provider aware or the first intervention with abnormal vital signs, we want to go through what we think are core components and essential components to a maternal early warning system. And this should work both for people who are at the point of considering implementation or are developing their tool, but also for people out there who have already developed a tool. I think looking at the components to strengthen what you're already using is of benefit. So in our algorithm, we start with the vital signs that would trigger the maternal early warning system. If people have already implemented a system that uses a scoring or a different algorithm at this point, we're not saying you need to go back and change your system, but otherwise, if you're still in the process of getting ready, we would recommend using the Council for Patient Safety, which is the maternal early warning system available on the AIM website under the toolkit. So once a vital sign that is recognized within your system as triggering the system occurs, the first line is triggering the maternal early warning system. The next should be notification to the responding provider, whomever that is within your system. So that can apply to a nurse midwife or a CRNA or an obstetrician or a family medicine physician, whatever works within your system. The first line notification occurs. And if your hospital is using standing order sets or standing delegated order sets, these should be initiated immediately, not waiting for the provider to come to bedside if it's not going to be an immediate response. We would recommend that the responding provider is at bedside within 60 minutes. The exact time can vary with your patient population and what you determine is appropriate within your system. For example, both of our hospitals use less than 15 minutes based on our patient population. In settings where a provider might not be in-house and is your responding provider, it might be reasonable to go to 60 minutes. And then the next very important part of a maternal early warning system is if that responding provider is not available to be reached immediately or cannot come to bedside within 60 minutes, or if your first line order set hasn't occurred immediately, then your hospital needs to have a specific MEWs escalation process. In other words, who is the second provider that you would notify, and make sure everyone knows and has been educated on that process. If the responding provider is at bedside within 60 minutes and order sets have been initiated, including treatment, then the following plan of care would be according to the patient's condition and the provider's evaluation. And at this point, this is where the process can flow into whatever your hospital QI bundle might be. So for example, if the patient has hypotension and tachycardia and has had a postpartum hemorrhage, the response portion of the AIM postpartum hemorrhage bundle. Or if a patient has severe range blood pressure, at this point it would plug into your hospital QI or protocol for hypertension and should result in immediate treatment. And importantly, I want to highlight treatment for things like hypertension shouldn't wait for a provider to come to bedside if it's not going to be immediate. And this is where those order sets and treatment with antihypertensives is important. So while this is the general protocol that we recommend, it does need to be individualized for your hospital. And so the box at the top right is specifically discussing what needs to be addressed within your hospital. So who is your responding provider? How are they notified? How quickly do you expect a response? We illustrated that in both of the hospitals we represent, that response is 15 minutes. How quickly do you activate standing order sets? And what is your escalation plan? And as previously mentioned, the differential diagnosis behind each of these MEWs triggers can be fairly broad and really depends on exactly the criteria, but this is where integration with your hospital's various protocols. As we have previously mentioned, these are requirements for maternal levels of care that many hospitals have things like a sepsis protocol. So for example, if a patient triggers for hypotension and tachycardia and has a fever, obviously sepsis is one of the important differential diagnoses. And if your hospital is using an order set or is following the CMS criteria, this is where both a evaluation by the provider and beginning those specific portions of your protocol are important. So beginning IV fluids, antibiotics, blood cultures, and lab evaluation while you're waiting for the physician to come to bedside. So for the important action steps in implementing your maternal early warning system, or if you already have a system in place, going back and looking at your components and strengthening them or adjusting them to make sure you're adequately meeting these criteria, we recommend educating all of your healthcare personnel on the vital signs or the system that would trigger the maternal early warning system. Who you feel needs to be educated depends on your system, and it's important to make sure you're considering, for example, the emergency department or an intensive care unit that might treat maternal patients and making sure they're aware of the maternal early warning system as well. Creating a specific response system within your hospital. So not just if this patient has an abnormal vital sign, notify a provider, but rather a specific system where everyone knows if you have a MEWs trigger, this is exactly what should happen in that scenario. Creating and educating the escalation system. So if that immediate first line response doesn't occur in the format that you feel is optimal for your patients, whether that be 60 minutes or 15 minutes or an order set, then making sure everyone knows exactly what the next step is so that patients don't have a delay in treatment in these serious abnormal vital signs. And then lastly, tracking outcomes related to the MEWs triggers to make sure the system you have in place is doing the effect you desire.
So now we wanted to open it up to any questions from the audience. We do have a chat screen where we can see your questions and we can answer them. And there was one question that I believe has already been answered, but we will have both the slides and the webinar available for viewing on the website, probably a little bit later in the week, but they will be available following the webinar. And we're just going to pause for a moment to give everyone a chance to type in their questions. You'll have to type it into the chat that's available to everyone, and we can see them and then answer them. So one question asks, how soon do we want to roll out this process? And the answer would be as soon as possible. And if there's any assistance that is needed for any of the hospitals who have not yet rolled this out, we are available to assist with that. We do have a QI nurse. Her name is Amanda Wagner, who I'm going to move to the next screen actually, so you have that contact information. So our technical assistance is can come from our QI nurse, and here's the contact information to get in touch with that person. Yes, we do have a badge card, and we can actually, one of the questions was, we'll get the slides, but do you have a PDF of the badge card? So we are happy to share that as well. So we do have two different versions of the badge card. They're very similar, but we are happy to share those. The badge cards are worn by all of the nurses and the patient care assistants at both hospitals. And one side gives the MEWs triggers, and the other side gives kind of a process flow of who to get in touch with, when, and if you haven't gotten a response, how to escalate. And so we are more than happy to share those. We can put that on the website as supplemental materials. So there's a question that is looking at implementing the MEWs T, as it is the only trigger with outcome data. Can you discuss? So yes, we're happy to talk about that. We have in our prior webinar presented both systems before and said that it is kind of fine to tailor it to your institution and your hospital. The scenario or the MEWs triggers that we are proposing are where you have a single trigger that would activate a particular response. And as you mentioned, there isn't outcomes data on that quite yet. We do have our own internal hospital data, which has shown a significant reduction in time from abnormal vital sign to resolution of that MEWs trigger, and also a reduction in hemorrhage and transfusion of 4 more units using the algorithm that we have gone through here. The other algorithm that you're describing does have literature that supports its use, and if that is what's best for your hospital, that is slightly different in that it takes either 2 triggers or 1 really bad trigger, and then you go down a cascade of particular pathways from a standpoint of what you think the differential diagnosis is, and enacting order sets. So we're not saying that one is necessarily better than the other, but to try and pose a single uniform process, or that's the one that we chose to propose.
I would also, this is Carrie Eppes, I would also add, while that's the first publication in the United States, there are other publications outside of the US and in other systems. And I think what we don't know, is it the specific tool or is it the process? I would say anecdotally, it's the process. So what MEWs trigger, scoring, trigger, the Larry Shields algorithm, the Council for Patient Safety, it actually isn't, in my opinion, the specific tool, but the process, and that everybody knows to evaluate and do something with that patient quickly. And so while that's the only tool published on in the US, that doesn't mean that that's the only one that is appropriate for our patients.
Okay, we're getting a lot of questions, so we're thank you. We want to make sure we answer them all.
Well, we just saw one about in-house if they have.
Oh yes, in-house providers. So if there is an in-house provider 24/7, someone who is an obstetric provider, we would recommend a much shorter time interval at getting to the bedside. So. And in that scenario, we do recommend 15 minutes to the bedside. Now, that's a scenario where you may or may not have enacted order sets in the meantime. If it is severe range blood pressure, it would be appropriate to treat that as the provider is on their way to the bedside, but the expectation with in-house providers is that they are physically present within 15 minutes. Now, we know that in some hospitals that don't have in-house providers, it may be that you're calling in someone from home, and that's where we say it should be no more than 60 minutes for the provider to get to the bedside. However, in that scenario, you should also be doing something while you're waiting for that provider. So whether it's treating the hypertension or ordering laboratories or imaging to assist with your final diagnosis.
And I think this is also an important thing to consider if you don't have in-house providers, is who else is in the hospital, because most settings will have somebody, whether that's a CRNA or a nurse practitioner in the ER or the ICU physician. And so trying to make sure you're tailoring how quickly you're responding to your patient population.
There's a lot of questions about order sets and if we would be willing to share order sets. Because we do have 24/7 providers in the hospital, we don't have standing order sets at our organizations that we would be able to share. We can certainly see if there's other organizations that might have some, but we don't have that.
Meaning our process isn't delegated order sets, although we do have order sets for things like preeclampsia or sepsis that we can share.
Now, I wanted to address, there are several questions about getting MEWs trigger alerts integrated into the electronic health record, specifically Epic. Really, there's a lot of answers for that, especially depending upon which system that you have, but really the first goal is changing the culture of the bedside staff to recognize that a trigger is occurring and then to alert somebody. So even if we don't want you to feel like you can't implement MEWs because you don't have it in the record, in the electronic health record, you can do it on a badge card, or just basically recognition is the first thing that needs to happen. And then when people hear MEWs, that they respond. And then how you integrate it into your electronic health record can be something secondary after your system has understood the MEWs process and implemented it. It definitely shouldn't be a barrier to implement.
And you shouldn't wait for the electronic health record to trigger before your system is triggered for all the reasons that Kristen just said, meaning that is a delay that should be avoided.
Right.
There's also questions about getting buy-in and getting buy-in, and also how long it takes to get everyone onboarded. And that obviously, it's going to depend. I think with any QI project, you need to have champions. And so, and a physician and a nurse champion. And then once you get those champions, going and telling the stories. And I think, again, we always hear it's really helpful to tell a patient story. We all can create or can recall stories of patients who are clinically deteriorating for hours before something was done because either the triggers were going unrecognized or they were not being responded to by the appropriate level provider. For example, in a hospital that has residents, if you've got interns trying to take care of things that they really just don't have the knowledge and skill to handle, then those MEWs triggers, even if they're going and evaluating them, they may not get managed appropriately. So it starts out with champions, and then the it out, in all honesty, it can probably take a few months. It's not necessarily something that you decide to do today and it's happening next week, depending on how large your organization is, depending on how many people you need to train. But the most important thing is getting started. And once you get started, there may be tweaks to the system as you go. As you audit your process, you might realize that there's something that works better for your system than what we proposed. But once you get started, it will probably still take a few months to fully roll it out.
And I would say just for those of you who are participating in AIM, this is one of the most common questions is how do you get buy-in from various entities and how do you create change? And undeniably, my opinion would be that that's the hardest part of quality and safety, but this is where potentially starting in a smaller area, so only in your triage unit or only in labor and delivery or only in postpartum, and and expanding it to a larger group after you've worked out the kinks, I think is really valuable.
There was a question about the patients that are impacted by MEWs or the patient population that we use MEWs on. And so we do recommend that MEWs is used for your triage patients, your labor patients, and your postpartum patients, including antepartum.
In other words, that there are no exclusions.
Right. And then also, if patients get readmitted onto the obstetric service, that we do apply MEWs to those patients as well. So if a patient comes in a week post-delivery with hypertension, she would also trigger MEWs if she was to have an abnormal vital sign that met the criteria.
And I think a lot of that is because physiologically, we know pregnant women are different than other people, and that includes time periods postpartum. And so these vital signs are very specific to pregnant populations, and so should touch anywhere that pregnant women are. Oh, somebody's asking about changes in outcome. So there's a question. So people are asking, have you seen any changes in outcome based on time and treatments? Yes. There's certainly a difference in the publication by Larry Shields of the MEWs system, in particular the time to treatment of hypertension and severe maternal morbidity both decreased. Internally, from tracking our own data, we saw significant decreases in some of the components of severe maternal morbidity and the difference in response time. In other words, the time from abnormal vital signs to normalization after the maternal early warning system.
There's a question about urine output every 2 hours for laboring patients. And no, that's not a recommendation. Just measuring it when she does void or when you do a straight cath, obviously, is what we do. But no, I don't think there's any standard of care that says that we should be measuring urine output every 2 hours.
But if you're measuring it with whatever frequency and you divide by the number of hours, if it amounts to less than that within 2 hours, that's really more what the trigger is. In other words, it's definitely oliguria.
Correct.
And that would apply oftentimes to the post-op patient, so status post a cesarean. And if she's being monitored and you call a MEWs trigger for decreased urine output, if she's also tachycardic, then we're obviously going to be concerned about hemorrhage and proceed that pathway. Or if she went into her cesarean with choreo, then we may be worried that she's now septic. So it may be in the patient who really does have a Foley post-operatively. But again, if they don't have a Foley and you're intermittently monitoring urine output, it would just be to divide it to see what you are getting on average hourly. And I guess we've had a few questions about how many weeks postpartum following the triggers, just to be specific. I would probably say up to 6 weeks postpartum is when we would kind of consider the patient still postpartum.
But in an inpatient setting at this time.
Correct.
Yes.
Like if they got readmitted up to 6 weeks postpartum.
There's a question about, has anyone rolled out a maternal MEWs system after MEWs was already rolled out housewide in your hospital through the adult population? I know that that wasn't the case for us. Our hospital's now looking at another early warning system, I think based on some of the things we learned, and also mostly to meet sepsis criteria. So it's the exact opposite. I don't know if you guys obviously, our other hospital here is obviously mostly covering women and infants. So their process wasn't the reverse. But if there's anybody else out there that has, feel free to chat, and we can tap into you for future action periods or webinars and how you might have adapted the vital sign system in your hospital to the maternal early warning sign. I would say the only experience we had in our hospital is we did our maternal early warning system, and then our hospital tried to develop a more robust sepsis protocol. And so, sorry for the cough, we were defining, triggering SIRS criteria, which is what our hospital used. And we were able to argue to turn off the best practice alert for SIRS based on our experience with our maternal early warning system, that we wouldn't be creating any big gaps in patient care. And SIRS was just triggering and would trigger in all of our pregnant women.
There was a question that I saw earlier about monitoring like the triggers and what the process is kind of for auditing. And so what we use at both hospitals now is just kind of keeping track of your MEWs triggers, and that way you can go back in. You can either do random audits and go into charts, just pick random charts and make sure that if MEWs should have been activated, that it was. And then you can also keep track of the ones that are known activations. And when you go in that chart, just make sure that the process you have outlined is being followed. And that can also feed back onto, are there things about the process that you may need to adjust?
Our journey at our hospital was reviewing all patient charts for a period of time. I think if we could go back and do it again, my one piece of advice to all of you who are just starting would be, if it's possible, to build it into a flow sheet from the beginning, to do so that you don't have to go back by hand through charts. And then that's a component that is able to be audited when you're looking in your health record. But if not, a random sample by paper, by hand is also reasonable. I think the problem is this isn't a system that triggers a lot, and what you want to make sure you capture is the people that should have triggered that didn't. And so that does involve a fairly large number of patients if you're only triggering a small percentage of the time.
And there's another question about how many triggers you need to activate it, and that's going to depend on the system you use. What we are proposing, what we've outlined, is where only one of those things would need to be abnormal to trigger, to activate a MEWs and to call the provider to the bedside. The other system that was described earlier within the question and answer session, where it leads down a pathway of potential order sets, that does require 2 triggers or 1 severe trigger. And so it depends on which system you're using, but the one we have described is you only need 1 abnormal trigger.
There's a question about what would you track in a monthly report. Actually, for our smaller reinforcement cohort, we're testing out measures that just started with the summit. So we'll have discrete variables that other groups have tested and kind of done a beta testing. But in the meanwhile, the things that we tracked were ongoing. Our hospital's tracking severe maternal morbidity. So whatever outcome measures you're otherwise tracking, I think are interesting to look at over the time period of MEWs. But time from abnormal vital sign to provider response or to normalization of the vital sign, whatever is easier for you to track, if not both. And what percentage of the time MEWs is triggered and what percentage of the time it's triggered when it should be triggered. But hopefully we'll have some good outcome and process measures to share that a smaller group has tested.
And we're happy to continue taking more questions.
There have been a fair number of questions asking about specific systems in different groups. I think personally, my approach is simplicity goes a long way. So that's why we prefer the Council for Patient Safety, or we recommend using that algorithm to start, mostly because if people are sitting there calculating scores, it adds various time and you're a little bit more likely to miss things if you require all sorts of different vital signs for points. And the same thing why we advocated to turn off SIRS in our patients. If you've got too many different best practice alerts firing or different systems in different places, I think it gets confusing. So our approach is to use our maternal early warning system for everything and then feed that into sepsis or postpartum hemorrhage or hypertension or any other major initiative. So we use one, and I think that simple factor and that everybody just needs to remember one goes a long way. That doesn't mean that you might not find in your hospital after you review cases that you need to adapt something, and then that might be totally appropriate. But certainly when you start, I think starting simple is very important to get people to buy into it. While we're waiting on more questions, if anybody has them, we just wanted to thank the over 250 participants that joined and make sure everybody knows we're going to make the slides available. Amanda Wagner is our QI nurse, and she's available for any technical assistant needs, including conversations or site visits, directing you to materials. So please tap into that resource if you need it. And again, thank you everybody who has joined so far. And we'll give a few more minutes for any other questions.
We'll be sending out a survey after conclusion of this webinar, and we would really appreciate your feedback. Let us know where your gaps are, where your questions are, so that we can direct our next action period call, phone call, and webinar towards your needs, whether that is IT, education, policy development, order set, whatever that need might be. Please let us know.
Thank you all. It looks like we've answered all the questions that have come in. We haven't gotten any more. So this will conclude today's webinar. Thank you all so much for participating.